Hello, thanks for joining us. My name is Richard Wood. I'm the Chief of Pediatric Colorectal and Pelvic Reconstructive Surgery here at Nationwide Children's Hospital. And I'm joined this morning by my colleague, Dr. Jayanthi, who's our Chief of Urological Surgery. And we're going to talk with you about patients with cloacal exstrophy. Hey Raman, thanks for joining me.
Thanks for asking me.
So just wanted to start off by speaking a little bit about the fetal center and how that's impacted our ability to care for patients who haven't been born yet. I just wanted to find out a little bit about how you've gotten urologists with an interest in reconstruction involved in the fetal center.
Yeah, I think that having a fetal center and being able to talk with families even before the child is born is so important. You know, as we know, specifically with cloacal exstrophy as well as other conditions, these are extremely complex, challenging conditions for anybody. And in the old days, before we had ultrasound, kids were born and families were hit with a tidal wave of stress, worries, concerns, all this information when the child was born. Because we have the fetal center and we make these diagnoses even before the child is born, we are able to better educate the families on all the challenges that they may face afterwards. And it's not only just education for the families. We as the surgical team are better able to know what we're going to be facing before the child is born, and we will already have had a plan by the time the child is in front of us. Yeah. So the fetal program is so important in making sure these kids get the care that they need.
Yeah, I couldn't agree more. We see a lot of children with anorectal malformations that are not diagnosed antenatally. And if we see the trauma that those families go through with the way they get that information completely unexpectedly, and then, it's not just your child has an anorectal malformation, but they also have a renal problem, or they have a tethered cord, or they have a cardiac issue. And so it's just sort of one hit after the other. And a lot of our families really struggle with that. And it takes a long time to recover from that. So I think the point you make about having that information before the child is born, having those conversations to understand what's happening, having the space to read and really gain knowledge and empower themselves, I think really helps families. And so I think the advent of a formalized fetal center here, I think is a big gain. I think the other thing which is worth noting is a lot of fetal surgeons are extremely talented surgeons, but they do a lot with congenital diaphragmatic hernia, esophageal atresia. That's the sort of wheelhouse of care, spina bifida surgery. But I think with both of our teams having surgeons who do reconstruction for cloacal exstrophy and cloacal malformations involved in that counseling, I think is really helpful for families, because it allows them to create that attachment with surgeons before the child's even born, and then those are the doctors together with others that will help take care of their children afterwards. And I think that also helps, because otherwise they get bonded to whoever the first person is, and then suddenly they're getting handed off, and that feels weird. So I think there's definitely a benefit to having the reconstructive team engaged in the fetal program, and so far we've had really good feedback about that.
Absolutely, and there's one other concept which I think it's important to raise. It's a difficult concept to discuss, but I think it's extremely important. And that is that I think that families who are faced with a child who has a really difficult, challenging condition actually go through a grieving process. Let's face it, we're both parents. Yeah. We went through this years ago, but when you find out that you're about to have a baby, you have certain expectations, hopes, and goals, and all of a sudden you're told that your child has major medical issues. There is a grieving process that parents go through. And I think that by having conversations with parents, even before the child is born, we can help them with those emotional aspects beyond all the medical aspects. We really have to address the family holistically to try to give that family the best outcome possible.
Yeah. No, I think that's really important, and I think the fact that we, have psychology support within the Reconstructive Center already built in because of the psychological impacts of some of the conditions that we treat together allows us to kind of use those resources and put them around families, because I think you make a great point that the psychological impacts of this are huge, and that mourning that expectation of what I had for my child, which lands up being different, is a big part of it. So I think doing it before they're born is a key, and then having the right resources around them because of the systems we already have in place, I think makes a big difference. Yeah. That's a great point.
And along with that, I think that what I found very helpful is to be able to give parents examples of other kids that we have taken care of who are older, who have navigated all of these issues and are off and living successful lives. Yeah. And by having a large experience with these conditions, we're able to point to specific patients that we've dealt with as we speak to expectant parents. And that gives them that hope and that understanding that, yes, my child has this major issue, medical issue, but that's not going to define their lives as much as possible, that they have a future ahead of them. And I think that those are very important conversations to have with families.
So if we can change tack just a little bit, when the children are born and are admitted to the neonatal ICU, in those first day or two after they're born, and we have to plan some sort of definitive care, we talk just a little bit about the urological aspects of how we think about that initial care process.
Yeah, I think that with the initial, urological aspects, realistically, the urological issues are not as important as the colorectal issues.
Sure.
And I know you'll address this, but the main issue is going to be how to deal with the bowels.
Yeah.
But as we decide what to do, we have to think about not only what the child needs right now, but we have to realize that what we do right now will affect what we do a few years down the road. And it sounds cliche, but every child is truly different with these congenital anomalies. We have to look at the specific child's anatomy and then figure out what is right for that child. And what is right for that child may be completely different than what's right for another child.
Yeah.
But essentially, because with cloacal exstrophy, the bowels and the bladder are merged into one, the initial steps are to separate the two. Yeah. And then we usually just convert the cloacal exstrophy to the classic exstrophy where just the bowels are still exposed. And then we think about dealing with that when the child is a little bit older and stronger and healthier.
Yeah. Yeah, I think that's a really good point. I agree with you that there's a lot of benefit to having taken care of a lot of these patients together. I think with experience, you definitely, your systems become more robust, and I think our collaborative system works extremely well. And like you mentioned, every child with cloacal exstrophy is a little different. And the key tenet that we've always used is, don't burn any bridges. So any decisions that we make in the neonatal period, we want to not burn bridges that may affect our options when we're doing reconstructive surgery when the children get a little bit older. And I think some of those things we've learned a little bit more about in the last several years through some of the research that both you've done in urology and we've done in colorectal and done together. But essentially, a lot of the decision making that we do in that initial neonatal period is very much shared decision making. As you said, the goal is to deal with the omphalocele issues if they're there. Sometimes those omphalocele problems are so large that we can't, convert them to just a bladder exstrophy. But those are certainly the goals. I think, for many years the push went away from doing ileostomies to involving all the bowel within the fecal stream to help with nutrition and absorption, and that's certainly something that we very much in favor of. And then preserving as much bladder tissue as possible and not compromising bladder tissue, I think, is a key part of what we do. And getting the children set up so that, as you say, we separate the urine and the stool to prevent infections and really get them in a position where they can grow and thrive, and let them bond with their families and get bigger, and get them healthy. Obviously we acknowledge some of the children who have really big emphalocele do have some pulmonary issues or breathing issues around their neonatal period, and we definitely would deal with those. But usually, we're able to get those things squared away, and patients can then grow and thrive and develop outside the neonatal period until the time comes when we consider doing other surgeries to try and get their anatomy more definitively dealt with.
Yeah, and that makes me think about a very important issue. And what I'm going to say right now may not sit well, but I think it's a very important concept to think about with children who are born with these complex conditions. It is completely understandable when a child is born with a complex condition for parents to say, will my child be normal? We all want that. We want our child to be normal. And I think that we have to be really upfront and say, it depends on what you define as normal. So is my child going to ultimately urinate normally like other children? The answer is no. That's not going to happen. And I know that's a very strong statement to make. That may seem overly pessimistic. That may seem overly negative. But I think that we have to have a very realistic view of what can be accomplished. And the reason why I say that is there are so many kids in the past who have gone through multiple surgical procedures because we wanted to create normal, whatever that might be. And I'm not sure that's in the best interest of the child. And so we have to have those complex, challenging discussions with parents from the very beginning as to what is reasonably achievable, just to make sure that their expectations are appropriate and that we don't put a child through multiple surgeries which may not be ultimately beneficial to that child.
Yeah, I 100% agree. I mean, I think this patient population, if we're honest, has suffered from multiple examples of surgery over the last 25, 30 years that maybe didn't land up being in their best interests. And I think some of the research work your group has done with regard to the way these children empty their bladders, and some of the work our group has done looking at the way they stool, has been very insightful for us to be able to give patients real data to understand what expectations should be and not, tell any fairy tales, essentially. Because I think families, from my experience certainly, and you probably agree, if we can have a real conversation about what our goals of treatment are, that we want children, to be dry when they go to school, or to be not wearing a diaper when they go to school, and they'll be able to attend school, those kinds of things. Those are the kind of conversations we can have. Now, will they pass urine in the toilet like their peers do? Maybe not. But we need to frame our conversations differently. And what are those goals of therapy? Obviously, in the first couple of months after the child's born, there's still a lot of very stressful situations, so maybe we don't define that up front. But as we get towards doing definitive surgery, I think really, like you say, defining the goals of therapy and what we're trying to achieve and making sure that we're all very well aligned on that, I think is fundamentally important. Because, as you say, the best of intentions have led to surgical morbidity, which is perhaps something we would really like to try and get away from. And so aligning those expectations up front appears, certainly from our experience of late, to minimize that and hopefully provide patients with overall a good quality of life, but not necessarily the expectations of normality, which probably is unrealistic in certainly some of our patients, if not all.
Yeah, I think that that's just so true and so important to emphasize to families. You know, what I try to talk to families about is, despite all this stuff with the bladder, you know, that we have to deal with, you know, I try to paint them a picture that your child, as he or she grows up, you know, is going to play kiddie soccer, with all their friends. You know, can go scouting, can go camping, can swim in ponds and lakes, and just do all sorts of normal childhood activity. None of that stuff changes because your child has cloacal exstrophy. What may change is the way you pee or poop, but the total child, you know, life just goes on. And we really try to emphasize those points, you know, to families. You know, we physicians often have an assumption that we know what is most important to families. We kind of assume that we know what they want, and that may not be the case. And some things that we do commonly is talk to families and ask them, what is it that's most important to you? What do you need? What do you want? What are your goals? And we try to tailor therapies based on those conversations. And we could have two children who have identical anatomical features, but they may have totally different treatment plans if the goals of the parents are different. And so we have to really tailor treatment not only for the individual child's anatomy, but also the specific family's ultimate goals and wishes. That is a very important concept.
It is, and I think it's one of the really stressful things about, you know, for families who are taking care of kids with complex problems, is they're trying their best with the best of intentions to make the best possible decisions for somebody else. And so we're always trying to give them the data and the guidance to help them to make the decisions that would fit best with their families, and where possible, you know, sometimes allow some decisions to be made when the children are a little bit older and can be part of those decisions. And I know we've done that sometimes, where we've done a sort of a procedure which allows us to buy time but get children dry, and then let them decide if they say want a cath or something like that, and when they're old enough to do that, and then keep the option open to do that. But I think that has definitely allowed us to engage with families and create care plans that really fit around them and their quality of life, rather than, you know, some unrealistic expectation of normality or something like that. And again, to stress, you know, within cloacal exstrophy, there's a large variation. I mean, we see patients who have, you know, just from the colorectal perspective, we see patients who have, you know, a fairly normal length of colon, which, based on the research we've been looking at recently, allows you to think about things like doing a pull-through and an antegrade enema option when we do our definitive reconstruction. We have other patients who have very little colon, and we've looked at that and realized that if you do a pull-through with a patient with very little colon, they're miserable because they essentially have a stoma in their perineum, and all the horrors that come with diaper rashes with having a stoma there. And so being able to help families understand, like, you know, your particular child's anatomical variation allows us to consider these kind of options, which of those options fit best within your framework, rather than just say, well, whatever you like, and then the families try and make the right decision but don't have the data. And I know your group's worked a lot on that as well, and I think that's allowed us to have really sensible conversations where we can say, these are the outcomes we can expect with this anatomy. What do you think will work best within the context of your family?
Yeah. I think another very important aspect of care for these complex children is the following. Historically, with cloacal exstrophy, we've always just emphasized pee and poop, continence and defecation and so on. But I think that historically we've underemphasized outcomes and other issues of significant importance to families. And I'm specifically referring to sexual function and fertility. Yeah. I think that sometimes it may be odd to be speaking to parents of a little baby about that child's sexual function. But I think that we have to have those conversations. And we have those conversations early on just to prepare them for this type of conversations we're going to be having as the child gets older. And we have to think about all that. And as it may be hard for a parent to think about their 13-year-old thinking about sex, but they do. And so we have to be there to support these kids and these teenagers as they progress to adult life. And in our specific clinics, I often think about the fact that we have sex ed, for some of these kids who have complex genital issues, because we try to talk to them about the fact that there are multiple ways for people to have sex. Yeah. These are very, very important concepts for families to think about.
And again, for the little boys, I know you as urologists will have many of those conversations. I think also to emphasize for all the girls that we have in our clinic, we obviously have gynecology involved right from the beginning. They're involved in the initial surgery, and they're involved in the reconstructive surgery and become very involved with the teenagers. And I think one of the other things which we built over the last several years is our transitional care program, which is run by some of our physicians, and Dr. Geisha specifically, who runs the program, works here at Children's with us, but she also works up at OSU. And there's a whole team of folks up at OSU that take care of these complex patients as they get older. And so I think being able to reassure parents when their kids are born that yes, this is a complex problem, and yes, they're going to deal with issues as their child grows through life, but to be able to reassure them and say that there's a team that can take care of you from now, before you're born, you have an antenatal diagnosis, all the way through to adulthood, I think is very reassuring. And certainly some of the patients I've spoken to who have children with cloacal exstrophy have specifically wanted that reassurance, to know that when I get older, my child's still going to have a medical home to be taken care of in by people who take care of these problems, not just in little babies, but all the way through until they're adults, and deal with the fertility and sexual health issues that come up as they get older, and help deal with those issues with regard to their adulthood and how they see that and grow that. So I think you're right in saying that many parents really are concerned about that, and I was always struck with our cloacal patients, how many times they weren't that interested to talk to me about bowel stuff. They were much more interested to talk to the gynecologist about long-term fertility and sexual health, even at a younger age. And so we've kind of met that need by having gynecology involved right from the beginning, so that people feel that that's an important aspect of what we do for the female patients, and obviously for the boys, the urologists manage that. But I think it's a really good point that we have to deal with the whole patient, and we have to think about what are the stressors that parents have. And you raised a good point about what do we think is important, what do they think is important. About 5 years ago, we did a bunch of questions for families and doctors in the center, and asked them what they thought was important. And each group made a top 10, and there were only 2 things on both top 10s. And that was really sobering for us, because we realized that some of our questions that we wanted to ask and research were not what was important to families. And so we had to readjust the questions we're asking, they were much more what the patients wanted to know rather than like, you know, what we were interested in. So it's a great point that we've got to ask the questions the patients are interested in, not the questions that, not as much just the questions we're interested in.
Yeah, I think that when children are born with an anatomical condition, it is normal for families to think that surgery is going to fix this, and the child will get on with their lives. And I think the point that we're making here is that, you know, the management of kids with cloacal exstrophy is about more than surgery. Yeah. That to have great outcomes, and what do I mean by a great outcome? I mean, you know, a child who grows up to be an adult with a great self-image, who loves themselves, who feels supported, and going on wherever destiny is going to take them. That's what I mean as a good outcome. But to achieve that goal, it really takes the whole team. It's not just surgery. We have a whole group of people. We need to have a whole group of people involved to support that child as he or she grows and gets older with whatever their specific concerns might be at that point in time. Sometimes it's surgery, sometimes it's counseling, sometimes it's just having a conversation, you know, just so they feel that connection.
Yeah. So I wanted to thank Dr. Jayanthi for joining me this morning to talk about this very important problem of helping families and children with cloacal exstrophy, and to talk a little bit about the work we've done here to really try and create a medical home for these patients. And if you have any further need for information, please reach out to us through our website, which is on the screen, and we'll be happy to give you more information and how we could help your child and your family. Thank you very much.